Now call upon Dr. D Ramamurthy. He is going to talk about presbyopia lens exchange and update.
Thank you. No financial disclosure relevant to this presentation. Uh, Basically, the lens of a 25-year-old and a 55-year-old are really not the same, even though on the slit lamp they may appear absolutely clear. There is a significantly increased thickening of the lenses. As you can see here, this is the thickness of the 25-year-old and that of a 65 or 55-year-old. And there is a significant drop in the point spread function and the quality of vision and the modulation transfer function. Obviously, it's a less functional lens. And then, as we all know, there's a loss in contrast. Even differentiating between a blue and a black or a blue or a gray colors in the natural world becomes a little difficult. And most importantly, as we all know, there is an accommodation loss from almost 15 diopters when the child is about a year old. Beyond 60 years, it comes down to almost zero. So obviously, even though the lens might appear to be absolutely clear on the slit lamp, it's a dysfunctional lens. And this concept was introduced because even in a so-called clear lens in elderly, there is an increase in spherical aberration, light scattering, increase in the refractive index and the size of the lens. There's a loss in the transparency, in the ability to accommodate, and in the mesopic pupillary size also comes down. And as you can see here, this is called, you don't really need an eye trace to evaluate these eyes always, but just to demonstrate whenever the dysfunctional lens index is beyond 5, it is acceptable, but when it's less than 5, it's 1 point, like in this case, it's 1.57. In spite of the lens remaining quite clear, this is a lens which, if taken out, the patient might benefit. And this is just to show you a reasonably clear lens. The cornea is absolutely pristine. Almost the entire aberrations that are there in the cornea, in the optics of the eye, seems to be coming from the internal optics, which is essentially from the lens. And as you can see over here, the internal higher order aberration is in the range of 0.335, almost completely contributing to the total eye aberrations. And when you replace that lens, the natural lens with an aspheric single piece, then you see a significant jump in the dysfunctional lens index, coming back to almost normal levels, complete disappearance of the internal aberrations, and significantly enhanced quality of image that these patients enjoy. It's not just doing away with the refractive error, but even the quality of vision that improves. That doesn't mean that I go around replacing all natural lenses. The profile of patients who we take up for refractive lens exchange are usually patients in their 50s or 60s. They're most often hyperopes, where the eyes are otherwise totally normal. And very often, as we know, these hyperopes are having a concomitant shallow AC. And instead of doing a peripheral iridotomy, which is, of course, a simple procedure, if the patient is predisposed to angle closure glaucoma, just replacing this lens with an artificial lens creates enough space in the eye. And the patient should be highly motivated for freedom from glasses and really not looking for perfect vision. You can't ever mimic nature. What I mean by this is that if a 25-year-old comes with a -2 or a -3 diopters, we actively propagate the concept of refractive surgery, encourage the patient to go in for a LASIK treatment or a SMILE treatment. On the other hand, if a 55-year-old is just coming in for change of glasses, then it's not that we recommend that we go ahead and get your lenses removed. Quite often the situation is that the daughter or son has got a SMILE procedure done, enjoying perfect vision, and the mother comes and asks, what about me, doctor, can you do something? Especially if she's a hyperope, why not? We go ahead and suggest this is an alternative that's possible. So it's one of the greatest tests for the results of any intraocular lens, or for that matter, cataract surgeon, is to achieve day in and day out very happy patients subsequent to presbyopia lens exchange or CLE procedure, simply because these patients had good vision prior to surgery. All they required was glasses, and they don't want any compromise. So you may take on multifocal lenses, etc., toric lenses, etc., without all these devices. But if you really want to do clear lens exchange, then it's important that you evaluate the ocular surface, do a good optical biometry, understand the formulae, topography, abrometry, OCT, specular microscopy, and an experienced and a confident surgeon who is quite confident of the kind of results that he or she gets, the kind of astigmatism that's induced by the surgery. So It's a astigmatically neutral incision, as we all know. A temporal clear corneal incision of less than 2.4 millimeter has a centroid value of just about 0.1 diopter. So clean cut incision is what is important. In the bag implantation, an excellent centration of the lens, minimal PCO, minimal damage to the endothelium. Overall, very good, well-performed surgery so that the patient can derive the maximum advantage of the intraocular lens that is implanted. It's most often a clear lens that's there, so it's important that you get the surgery right. Some of these clear lenses can be reasonably challenging situations to handle. I don't usually use EDOF lenses in these cases simply because they do not give the kind of near vision that the patient expects. Most often it's a trifocal or a continuous range of vision lenses. And when it comes to a soft cataract where we are using a laser platform, then it's a sextant, and basically the hydrodissection is done through the incisions that are created. There's just sextants, no cylinders are done. And then subsequently, as you can see, the CDE remains at 0. All that you need to do is to chop along the segments that has been already created by the laser, then subsequently remove the rest of the nucleus in a very controlled manner, and then implant the intraocular lens of your choice, which I already mentioned, has to be a trifocal or a continuous range of vision lens. And of course, the patient has to be primed. A significant amount of counseling has to go into it. So I always delay the fellow eye surgery by a week or two, not only because of risk of endophthalmitis or TARS, but more importantly, gain valuable information about the kind of visual experience that the patient has. It's not just what your optometrist writes in the charts, but what exactly the patient's experience is, and whether they are comfortable with near vision, intermediate vision, the quality of vision, etc. So that depending upon the type of outcome in the first eye, titrate the fellow eye surgery so that not only as far as the power is concerned, sometimes you could vary even the type of lens that you are implanting. Obviously, sometimes there can be small residual errors in spite of all that you do. And invariably, we even tell the patients that a transepithelial PRK touch-up might be necessary to take care of the residual error 3 months later, which is done free of cost. Just to show you a typical case, a lady, 55-year-old, significant amount of hyperopic astigmatism and presbyopia. And you see that what she requires is a 27-28 lens. Even small amounts of astigmatism needs to be taken care of. The topography is absolutely pristine with a good cornea in both the eyes. The higher order aberrations are almost absent as far as the corneal surface is concerned, both in the right and the left eye. And subsequent to a bilateral trifocal surgery, what the patient ends up with is a very happy outcome. And so lens-based approach for presbyopia is effective. Careful case selection and counseling is necessary. Meticulous evaluation, flawless surgery invariably leads on to satisfied patients. And presbyopia is a lens disease. I think as surgeons of the third millennium, we should not learn to just accept it, and it's not a corneal disease. So treatment should be a lens exchange. And it takes care of vision for all distances and better quality of vision, especially in a high probe than with laser vision correction. Mind you, I never recommend it for significant myopia because of significant post-operative complications as far as the retina is concerned. And obviously, if you do a good clear lens exchange, there's no future need for cataract surgery. Thank you so much for your kind attention.
Thank you, Dr. Ramamurthy.
Very
I'd just like to ask you, sir, do you try to factor in the age-related change in astigmatism? Do you like to leave a slight with the rule? Because these are very young patients. They still have to go through all the age-related astigmatism.
As I mentioned, I take up only after the age of 50. And between 40 to 50, if at all, it's more of presbyopic phakic IOLs. Beyond 50 is when we do that. By that time, usually, the against the rule astigmatism, the shift from with the rule to against the rule has already happened. So whatever is the astigmatism that's left over is taken care of.
And suppose some power is left, then what will you do? The laser touch-up?
I showed you.
How many days or months?
Usually we wait for a period of about 3 months.
3 months.
3 months for the refractive error to stabilize.
Trans-PRK?
Most often it's a trans-PRK. It's a very highly demanding patient, is not, I find that most often with the current trans-PRK, first day post-op itself, the patients are quite comfortable. Occasional cases we have even done a smile, but usually it's very small errors that you need to treat
Yes. So after 3 months.
after 3 months.
How many such cases have you done?
I actually have those slides. I mean, you know, we analyzed about 220 eyes that we did in 21, 22. After that, we stopped analyzing because we became confident with this procedure.
What is the percentage of happy patients?
I would say, you know, it's
Unhappy patients.
unhappy patients with the, as far as the quality of vision is concerned, there are about 2 to 3% of patients. And let me be frank, I'm not being sexist on this, but it's more often ladies who do not require much of night vision driving, and those who are extremely motivated to get rid of glasses.
You are right. So